Today we're going to talk about the surgical management of pediatric patients with congenital intestinal pseudoobstruction. And unfortunately, there are many problems for us as surgeons with this disease. The most important one is the variable presentation and outcome. And anyone who's been in practice, and I've been in surgery since 1981, you can see different patterns of your patients over time. Some will get worse over time, some fluctuate, some actually seem to have minor symptoms that just aren't that severe. And it's hard for us as surgeons to determine which patients need surgery and which will are in a transient decrease in motility and will get better. The other problem is that the taxonomy of pseudoobstruction is very poor. What I mean by this is that what we really need to do is to have a very careful system of classification. Pseudoobstruction is a grab bag diagnosis, as is CIPO, and unfortunately that causes our whole field to be hampered. I think there's an analog in vascular anomalies where Dr. Mulliken at Children's spent much of his career just classifying the different types of vascular anomalies. And now, after about 20 years, we are getting specific therapies, and I think that is really a key for us. The other problem is that family history is rare. The majority of these cases are sporadic. So gene approaches are going to be difficult in this disease. Now, perhaps with the advent of inducible stem cells, we can have better idea of what the mechanisms are with these various diseases, but it's going to be difficult for us to apply the general way that we use proteomics and genomics to this particular disease process. In general, neuropathic disorders are more common than myopathic disorders, although both are quite frequent, and these are greater than mixed disorders. Greater than 60% of patients require partial or complete PN. You're well aware of that. Mortality is significant, and the mortality is primarily associated with PN-associated problems. And I'm going to speak to that a little bit. What we have is intestinal failure-associated liver disease, IFALD, and sepsis. And those are the two major problems that we see as surgeons in patients with CIPO. And it's a self-reinforcing type of loop. There's immaturity, and if one takes a look at patients with CIPO, there's probably a twofold increase in prematurity in these patients. And patients with immature livers tend to be particularly susceptible to intestinal failure-associated liver disease.